Well, good morning, everyone, and welcome to our Caregiver Skills Clinic on the very important topic of balance and fall prevention. We're very glad that you're here today. This is a community dementia education program of Alzheimer's San Diego. We're a local and independent nonprofit supporting people in San Diego County or people outside of San Diego County who care for somebody who is impacted by Alzheimer's disease or any other type of dementia or the symptoms thereof. We're really glad that you attended this program today. This is a critically important topic, one that is very close to my own heart right now. I am so excited to be co-presenting today with my colleague at Sharp Healthcare, Sharp Reese Steely in particular. Kathleen Uzunolu is a doctor of physical therapy and has a new certification, a geriatric clinical specialist. I hope I said that correctly. Kathleen is a longtime physical therapist, volunteers her time with us here at Alzheimer's San Diego to educate the community about the risks of balance issues and falls in people living with dementia and care partners as well. It's not only people with dementia who are at risk of falling, as you will hear, and to help us do something about that proactive prevention and reducing the risk of injury if one does fall. So really glad to have you with me here today. With that, let me just give you a quick review of our agenda, and then I'm going to hand things over to my co-presenter. Our agenda for this program, I want to acknowledge we really appreciate the partnership that we have with Sharp Healthcare. They are sponsors and big supporters of everything we do here at Alzheimer's San Diego. We couldn't do what we do. We couldn't make these programs free and available to the community without that support. So we really appreciate that. I'll be telling you more about us at Alzheimer's San Diego at the end of the program and additional support and resources that are available. And I also want to acknowledge that I am a certified trainer in a technique called the positive approach to care, developed by an occupational therapist named Teepa Snow, and many of her sort of principles of caring for people who are living with dementia form the foundation of some of what I'll be talking about here today. So important that I recognize where that information comes from. So we're going to start with sort of just an overview of falls, the basics of falls, why people with dementia are at greater risk of falling, but also why it's a risk for all of us. We'll talk through some techniques for improving your balance, including some sort of exercises, that tests and exercises that you can do to increase your strength and to hopefully prevent falls from happening. What to do, how to respond to a fall if it does happen. If you want a fall to be sort of controlled and not cause an injury, there are ways to increase the risk of that or the likelihood of that happening and help somebody recover from a fall safely. And then I will wrap things up with some resources for additional help from the community, but also from us here at Alzheimer's San Diego. I will hand things right over.
Thank you. So as Amy mentioned, falls are common for all of us, not just our loved ones with dementia or Alzheimer's. I like to say that falls are common, but they shouldn't be considered normal because most falls are in fact preventable. But the truth is that 1 in 3 of us over 65 is going to fall each year. Once we get to be over 75, it's 1 in 2. And that number actually gets higher with comorbid conditions, things like Parkinson's disease, dementia, Alzheimer's will actually increase your risk even above that. Falls are the leading cause of injury in our senior population, the leading cause of a loss of independence or admission to a nursing home. So it is something that we take very seriously because it's so common among all of us. Go ahead and switch slides, Amy. Thank you. I think it's important to kind of cover the many reasons that we fall. I often hear from patients who have had a fall say, oh, you know what, but it doesn't count because I was doing X, Y, or Z, or it doesn't count because this happened, or really there was just a snake in the carpet, it just came up and it grabbed my leg and pulled me down. It's important to look at why we fall in 2 categories. There are some things that we can't control, and some of those are within us, comorbid conditions such as vertigo, having an illness, having had a stroke, having dementia or Alzheimer's disease. Those are things that even just the way that our vision changes as we age, loss of sensation as we age. These are normal age-related changes in the body that we can't prevent, but we can be aware of. Things like muscle weakness and stiffness are things that we have some control over with exercise, but the fact is that we tend to be less mobile and a little less strong as we get older. And so these are things that we don't have the power to change necessarily. However, there are other factors, things like changing our environment or being aware of our environmental hazards, making sure that we're taking our medications as prescribed, making sure that we're not combining medications with substances such as alcohol or pain relievers, knowing that stairs are a place where many people fall, so having good lighting, having railings, having grab bars in the shower, reducing our clutter, things that are in our environment, we actually have control over, and that's where we should target much of our efforts in preventing falls, especially for our loved ones. If we're really worried about a family member or someone that we live with, rather than having them stop, not move, just sit in that chair so they don't fall, we should make the environment as safe as possible so that they can do things independently. One thing that I didn't mention that's on this list is fear. Fear is listed under an intrinsic factor. However, I think it could really go into both sides, because there's some things that we can do to help us overcome fear, but it's really important to be aware of how fear impacts our balance and our ability to prevent a fall. And I'll talk more about that a little bit later in the program today. I want to talk a little bit more about medications, which is the next slide. Be very mindful of specific types of medications that either we ourselves are taking or our loved ones are taking. Sleep aids or any medication that causes drowsiness, which includes, allergy medication. These things that cause drowsiness make you much more likely to fall, especially if you are waking up in the middle of the night to use the restroom, or just maybe not sleeping all the way through the night, as many people who take sleep aids don't actually sleep a full 8 hours, and that medication is still in your system, and you're much more likely to fall while that medication is active in your system. Cardiac medication can also increase the likelihood for falls, and the reason for that is especially medications that lower your blood pressure. When you stand up quickly from sitting or from lying down, we'll use that example of getting up in the middle of the night to go to the bathroom again. When you stand up very quickly, you can have a rapid drop in blood pressure that can cause lightheadedness, dizziness, or just cause you to just lose your balance. You're not going to stop taking your medication. However, you can be aware of the side effects and make sure you're taking that extra 30 seconds to a minute to let your blood pressure stabilize before you stand up. Or you can make sure that you have a walker next to the bed for that middle of the night trip to the restroom so that you know for sure you're not going to fall over. Pain medication or any other kind of opiate is going to alter your brain chemistry. It's going to alter your mood. It's going to make you a little less steady to begin with, but it's also going to make your decision-making skills maybe a little bit suspect. You may do something that's a little bit riskier while taking pain medication. I mentioned allergy medication because it has the drowsiness side effect. And then a big thing is alcohol consumption at baseline is going to increase your risk for falling, but alcohol combined with any of your medications will increase your likelihood to fall. Diuretics are like water pills. The funny thing about diuretics is that it actually just causes you to run to the bathroom more frequently, which increases your risk of falling, because often we're in a hurry to get to the bathroom and we're not looking where we're going. We are focused on the destination, not necessarily on how we're getting there. I'm not recommending that you stop taking any medications. I'm just recommending that you really read the side effects thoroughly and know which ones are going to impact your safety and your risk for falling. Know how your medications are interacting with each other and how they interact with different foods or drinks. Talk to the doctor or pharmacist about any concerns that you have, especially within the first few weeks of taking a medication. You know, if you're feeling some funny symptoms, it's important to talk to the doctor about that. And know that when you change your medication or start a new medication, it takes your body a while to adjust. So you're actually most likely to have a fall in the first 2 weeks after starting or changing your medication. All right, I mentioned that falls, the likelihood of having a fall increases as we get older. Again, there are some things we can control, some things we can't. You can't control your age as much as you try. You cannot slow down that process. Time happens to all of us, but being 85 or older does put us much more at risk for having a fall. It just means we need to take steps to reduce our risk. Being female increases our risk for falling. It just has to do with muscle mass and frailty and bone density and things that just affect the female gender differently than the male gender. Being homebound or living alone increases the risk for falls, and that's for a couple of different reasons. When we are less active, our risk for falling, actually increases. And so the less that we do, the more likely we are actually to have a fall. History of falls: if you've had a fall before, if you've had multiple falls before, your risk of future falls increases. And then taking multiple medications, especially the critical number is 4, more than 4 medications, will significantly increase your risk for falling just because of the way that those drugs interact with each other and interact with our bodies. Amy, I think next is you.
Oh, sorry. Thank you. The final wrap up here and transition into my section is just to point out that people living with dementia, in addition to all of these fall risks that Kathleen has just described, you layer on the complexities of living with cognitive impairments, experiencing a narrower field of vision, which I'll describe here in a moment. And that is why the risk of falling is so much more significant in people who are living with dementia. So I'm going to give you a very quick tour of the brain. This is very high level. This is not complicated, but it is really helpful, I think, for a lot of us to understand why it is that these, I think sometimes it can be hard for people to connect the dots. Why does having a memory problem make me more likely to fall? Right? Alzheimer's disease and other types of dementia are much more than a memory problem, right? They are the convergence of a wide array of different symptoms, and they are due to physiological changes that are happening in the brain, structural changes to the brain cells themselves, as well as chemical changes, the ability of the brain cells to connect with each other. So as the brain is experiencing the changes related to whatever type of dementia the person is living with, this is going to have a significant impact on their ambulation, their ability to walk and be mobile independently and safely. So let's start with when there are changes in the temporal lobes of the brain, in the center of the brain. This is where we tend to see Alzheimer's and most types of dementia start in that region of the brain. And that is the part of the brain that controls our memory center, specifically our short-term memory. So when a person is experiencing rapid forgetting, disorientation, difficulty with sequencing, how might this manifest? This might be maybe somebody who has a history of balance problems and uses a cane or a walker. They really need that device when they sit up, when they're transferring from a seated to standing position from the couch or from their recliner, for example. If they have rapid forgetting, if they have difficulty initiating something that takes a series of steps, like getting the cane, grabbing the walker, recognizing that that is my cane, remembering, in fact, that I am a person who uses a cane, right? All of those types of changes are going to impact a person's ability to ambulate safely. Also, when there is damage in the frontal lobes of the brain, this large region up here behind our foreheads, this is where we see behavioral symptoms emerge. So different types of dementia sort of progress in different ways, but most people with most types of dementia are going to experience some damage in every lobe and every region of the brain eventually. So when there are behavioral changes, excuse me, how does that affect a person's, excuse me, risk of falling? So we may see a person withdrawing or becoming sort of apathetic, right? Not wanting, maybe I am aware that I'm experiencing some changes to my strength, my balance, and I should do those exercises that my care partner or my healthcare professional has recommended, but I don't feel like it, right? That difficulty with initiating, being able to get started on a task and becoming more apathetic towards self-care absolutely can have an impact on a person's risk of falling. And I think maybe more than anything else, the frontal lobe is sort of the seat of our executive function, the ability to take in lots of different types of information and quickly make a decision, render judgment, use your, not make impulsive decisions, but instead sort of think something through. When there's damage in that part of the brain, what we see is a reduction in a person's awareness, what we call safety awareness. Knowing when I step off that curb, I'm more likely to have a fall. There is a curb there. Maybe I should take that person's arm who's offering it to me, right? If I don't have any safety awareness and you're offering your arm, right? And maybe I'm not aware that anything is changing with me. Why would I take your arm? I'm fine. I can handle that by myself, right? Carrying a big bag of groceries up and down a staircase because I no longer have the awareness that this is potentially a problem. When there are changes in the parietal lobe of the brain, the occipital lobe back here, sort of very closely related to the function of our eyes, and the cerebellum, we see a different set of symptoms and expressions of changes in the person with dementia. We're likely to see difficulty with language comprehension, so not just the verbal ability to speak, but the ability to understand what you read, to understand the words that someone is saying to you. So maybe my care partner is giving me instructions on how to, reminding me that I need to grab my cane, grab my walker, right? Again, if I don't, I've got a short-term memory issue that makes it hard for me to remember that I need to use it. And I'm having difficulty understanding the words that that person is saying to me because they're communicating too quickly, they're giving me too much information, too many steps at one time. I may just sort of shut down and not be able to follow those instructions. Something that we see in people with dementia is that it's often easier for them to understand visual cues, visual information versus things that they hear. That has something to do with hearing loss and the likelihood of experiencing hearing loss as we age. But it's different. It's more than that. It's actually that we just have a lot more sort of wiring between our eyes and our comprehension centers in our brain than our ears. So longer in the disease process, most people with dementia are going to respond better to visual cueing, saying to that person, please put on your slippers. I don't want you to slip in your stocking feet in the house. Saying it is one thing. It's another thing to show them the slipper, right? To point at your own foot or to hand them the slipper and ask them to put it on, because then there's a visual cue to accompany that. So the fact that people are having difficulty understanding auditory language or reading signage, for example, this increases their risk of falling, as well as that difficulty with the recognition of the function of an object like a walker, a handrail, a light switch that will illuminate an area better so that you can see it before you walk up that stairway, for example. All of those things increase the likelihood of a fall and injury from that fall. And finally, there are physical symptoms of dementia as well. I think many people are not aware of that. We think of the memory symptoms, we think of the cognitive and sort of problem-solving thinking problems and the behavioral changes, but there are physical symptoms as well. So people lose some of their manual dexterity, major sort of motor functions, sensory perception changes. It's not so much that your eyes or your ears, lose they're not losing their ability as sensory organs simply because of the dementia, but what they're losing is the brain's ability to tell them what that is. What is that smell? That's the smell of smoke. I need to respond to that and get out of here quickly, right? So they can still take in the visual, auditory, olfactory, or sense of touch information, but their brain has a hard time telling them what that information means and what they should do about it. A couple of changes too that we frequently see in people with dementia is sort of a shift in their center, their balance, their center of gravity. We see people, you can't see me demonstrating this on Zoom here, but we see people sort of shifting forward, walking on the balls of their feet, looking down more often while they are walking. The primary reason for this is a significant change to the person's field of vision. So visually, if you're able to see this on the screen, this is just sort of an example of what these changes to the visual field in a person with dementia kind of look like. If you were standing at this vista, looking at this landscape, and you had a normal sort of middle-aged adult size field of vision, which is roughly 180 degrees or so, you'd be able to take in this whole picture. If you are a person who's living with dementia, even in very early stage dementia, most people with dementia, because of those structural and chemical changes in the brain that I just described, are living with what we call kind of a scuba-sized view of the world. It's as though they are walking around in the world wearing a scuba mask, a very narrow field of vision, which, as we age, our field of vision does narrow a little bit as we age, but we're talking very small for a person who's living even in the very early stages of dementia. So this is part of why we see somebody kind of leaning forward, developing a little bit of a shuffle, even pretty early on in many cases, because they're not able to sort of also see the ground while they're walking because that field of vision is so limited. As the disease progresses, this field of vision just gets smaller and smaller. So we'll see the step length getting shorter. We'll see people having a hard time sort of paying attention to anything besides the task that they are working on, right? When they're holding a pen and writing, they might be sort of leaning down, looking at what they're writing. They no longer have any vision of anything else that's happening in the room around them. So we refer to that as task vision. And then it just continues to get narrower and narrower down to sort of monocular vision. People with dementia can still see out of both of their eyes as long as their eyes are healthy, but their brain begins to have difficulty processing information from both eyes at the same time. And so you know what it's like to look through only one of your eyes. Now look through only one of your eyes and put on those goggles, right? Things become, depth perception becomes really distorted. The ability to interpret contrast is impacted, and significant safety issues for obvious reasons. Late stage in the disease, many people will have near total vision loss. It is not unusual. So a couple of things to keep in mind. Unfortunately, dementia is progressive. We don't currently have a cure. We don't have a means of prevention, nor do we at this time have an effective form of treatment, a way to actually halt or even slow down the progression of these symptoms. We're very hopeful that such a treatment is on the horizon, but at the moment we have to think about dementia as a progressive loss of function. So that is to say, we're not helping people with dementia rehabilitate, not helping them learn new skills. We're not helping them regain lost skills. Unfortunately, what we're doing is called habilitation, figuring out where they are in this moment and supporting them as best we can in that moment. So the positive approach to care techniques that I mentioned at the beginning when I was introducing myself and my training and my orientation as a dementia educator teach us to learn to do tasks with the person with dementia, to sort of come alongside them, figuratively or literally, do things with the person who's living with dementia rather than sort of stepping in and doing things to them or for them. We want to help people feel as autonomous as they can in their daily lives. Risk is a part of life, as Kathleen alluded to, and we'll continue to talk about. Falls are a part of many people's lives, but there are some things that we can do about it. But what we can't do is wrap people with dementia in bubble wrap, right? And make sure that nothing ever happens to them. Risk is a part of all of our lives. We have to be realistic and think outside the box when it comes to issues of safety and autonomy. Anything you'd like to add there?
Yes, can I interject for just a
Yeah,
minute?
please.
I love the way that you explain how we are not so much rehabbing. We're not trying to bring people back to where they were previously. However, I will just make a plug for all of us in that exercise. We call exercise neuroprotective, but what it really is it's just very healthy for our brains. If you think of dementia as sort of someone's baseline, and then the things that we do, how much water we drink, the foods that we eat, how much exercise we get, how much sleep we get, the things that we should generally do to be healthy people impact people with dementia more. So when we talk about that difficulty with initiation, that apathy, exercise is a mood booster for everyone, whether you have dementia or not. And so you are more likely to have a little bit of a lift in the mood if you've had some exercise or some movement that day. You're more likely to sleep well at night if you've had some exercise that day. And so with better sleep comes better brain function for all of us. Even though someone with dementia's baseline has some limits, you can still function to the best of that brain's ability with good sleep, good nutrition, and a bit of movement.
Absolutely. I couldn't agree more. I'm so glad that you said that. We speak frequently when we're talking about keeping your brain healthy. I think sometimes people think, well, I've got Alzheimer's disease, right? It's too late for me. And what we're frequently communicating to people is there are billions of brain cells in there, right? Yes, even when you've got Alzheimer's disease or any other type of neurodegenerative condition, there are still billions of perfectly healthy brain cells. So do what you can to keep those connections that are still intact, keep them functioning as well as possible. I'm so glad you said that. Thank you. So actually, with that, let's just get into some of the exercises. For all of you who are watching this on Zoom, I'm going to stop sharing my screen now. So you're going to see Kathleen's camera get a lot bigger. I just want to prepare you visually for what's about to happen here. And she's going to talk some more about balance and walk us through some techniques for improving strength, getting some of those exercises in, and preventing falls. Oh, you're still muted.
Sorry. So yes, I like to, I can't see all of you in this webinar format, but if you feel comfortable, if you feel like you're in a good environment that's safe, you have maybe something to grab onto, I encourage you to stand up and do this little demonstration with me, because it's really impactful to feel how each of our systems helps with our balance. So balance is not just one thing. Balance is a combination of our vision, our proprioception, or I like to think of it more of our sense of where we are in space, or you can think of it maybe as your sensation, like with touch. The vestibular system, which is the inner ear, it's your body's internal gyroscope, gives you a sense of where you're moving and how far and how fast. And then that combined with our muscle strength and flexibility, our ability to react to changes in position. So what's happening for all of us is our brain is constantly organizing all of this input from our eyes, our ears, and our sense of touch. And then telling your muscles, okay, right calf, turn on because we're leaning over. Left calf, turn on because we're walking. So it's constantly monitoring where we are in space and then altering the output to our muscles to make sure we stay upright. So if you would like to stand up with me, let's kind of see how this works. A little lower. So stand with your feet together, touching. You can be close to something to hold on to if you don't feel quite steady. And just stand there unsupported and just see how it feels. You can feel yourself shift weight from right to left. You can see yourself shifting weight from right to left. And if we make the base of support more narrow, either putting one foot in front of the other or standing on one foot, if you feel steady enough to do that, you notice that now with less sensory input, it's harder to balance, right? I only have the information coming from one foot instead of from both feet. So it's harder to balance. Similarly, if you stand on one foot and it's a little bit unsteady and you just take one fingertip and touch something nearby, just a little fingertip, it becomes so much easier to balance because you're giving your brain more input. Okay, let's bring that foot back down. The next thing to try. So stand with good steady position. So maybe bring your feet a little wider and just close your eyes and see how much harder it is to stay upright with your eyes closed, because now you've lost the input from your vision. And as Amy mentioned, we have a lot of brain space devoted to vision. So we use that information a lot to keep us upright. It's one of the reasons it's so difficult for people with Alzheimer's to stay balanced, because they're getting less input to the brain. The brain has less information to work with, similar to closing your eyes. You know, it's just a little bit harder to stay on your feet. And so we are constantly integrating these things for balance. And I'd like to say one more thing on that subject. It's a little bit out of order, but when we talk about using a cane or using a walker, you know, sometimes it isn't so much about supporting our body. It's not about holding us up. It's about increasing that sense of touch. If you have a cane to hold on to, you get more input to your brain. When that cane touches the ground, your brain has one more data point for where the ground is. If you're using a walker, you have even more data points because you have 4 legs and 2 hands to give your brain information on where you are, the slope or uphill, downhill, the unevenness. You just get more information about your environment. Okay. The other thing that I talked about, I alluded to earlier, is fear. So one thing I'd like us to think about, and one of the reasons for my plug on exercising more, is this idea of balanced confidence. So we mentioned that having had a fall before increases your risk for falling. Being afraid of falling increases your risk for falling. So one thing that we find that happens is falling and a lack of balance creates this negative feedback loop. It creates a cycle where you have fallen once and you're afraid of falling again. And so that fear of falling actually makes you move less. You're more likely to sit and ask somebody to do something for you, or just maybe I don't really want to get up and go do that by myself, or I don't want to go to that place without help because I'm afraid I'm going to fall. So you end up moving more slowly, or you avoid walking, which makes you deconditioned. The sedentary lifestyle, if you sit in the chair more, you're definitely not going to fall, but you're also not getting any stronger. You're not improving your balance at all. And so you end up with weaker muscles and less flexibility. That makes it harder to walk. And when it's harder to walk, we're afraid to fall. When we're afraid to fall, we move less. So it goes around and around and around. And one thing I like to demonstrate, and I will just do my best to show this here on the screen, is what happens when fear kind of takes over. So if you imagine I'm walking just on, let's say, a line in the parking lot, you know, a parking line. I'm gonna just walk in a line. It's fine, it's no big deal, it's very low risk. But if we take that same line and make it a balance beam, maybe 4 feet off the ground, suddenly I'm starting to look left, I'm starting to look right, I'm rigid, I'm afraid I'm gonna fall, and my body is actually less able to react to the balance challenge. Now you take that line and you make it a tightrope, make it something that's really high where if I fall, I'm gonna really get injured. And now I am completely frozen. I cannot move one foot in front of the other because I'm so afraid of what'll happen if I fall. And so, you know, the more we practice things, the more we walk, the more we move, the more we prepare meals for ourselves, or brush our own teeth or, go to the bathroom on our own, the more we do those things, the more confidence we have. The more we practice, the better we are. I think sometimes there's a fine line between helping somebody and keeping them safe and helping somebody too much and not letting them have any independence, not letting them take any risks at all, can actually be counterproductive. Because if you don't think they can do it, they don't think they can do it. And if they never practice it, they probably can't do it. And so again, we've been sitting for a while. If everyone wants to get up and move and maybe get a little oxygen to their brains, I'd like us to do a few little tests on ourselves just to see kind of how our balance is. The first thing we're going to do is just take a chair, whatever chair you're sitting in. And I'm sorry that you can't see my face, sort of either my legs or my face, but put your hands across your chest. You're going to stand up and sit down as many times as you can in 30 seconds. Okay, I'm going to set the timer. I know I can't see you, but I highly encourage you to participate because this is actually pretty fun, pretty telling activity. I'll tell you when to start. On your mark, get set, go. So you're going to go up and down, count your own repetitions. And you should be doing as many as you can in this 30 seconds. So be safe, but don't go too easy on yourself. And right about now is usually when people start to wonder if I'm really timing, because 30 seconds feels like a very long time. Keep going. Keep going. Okay, stop. Now, if you feel like you did really good on that test, you can go ahead and just throw your results in the chat if you want to brag about how many times you went up and down. The magic number for this test is 13. So we would love anyone who got 13 or more, we would think has a pretty low risk of falling. People who got less than 13 have a higher risk for falling. And this test is just a general test of mobility, strength, and power, but also endurance. I'm sure those of you who really participated fast as you can for 30 seconds are shocked at how much you're huffing and puffing right now. Because 30 seconds doesn't sound like very much exercise. And if you're huffing and puffing right now, I encourage you to do this daily or a few times a day because it's so good for us, for our brains, for our hearts, for our muscles to huff and puff a little bit. You don't have to do 30 minutes of high intensity exercise to get the benefit. You can do 30 seconds sitting and standing up in the chair and do that 1 or 2 or 3 times a day. And your fitness will improve, your strength will improve, and your overall mobility will improve. So it's a great, easy, safe activity to do. Oh, I have one person saying 12. Pretty good. And so now you know, okay, I bet you that it looks like Donna and John. I bet if we tried again and I said get 13 or more, you probably could. But this is a great activity for you to now start doing a couple times a week or a couple times a day. Another test that I like to do for people, especially if you're not sure or you haven't been practicing balance for a while, is sort of a threshold test. We're going to talk about this in a few minutes. Oh, hold on, there's more people bragging. Libby got 14. That's great. If anyone else wants to brag, I promise I will share your success. So the threshold test, I'm going to again move the camera to my feet. So we discussed how having a more narrow base of support makes it a little bit harder to balance. So the threshold test, we start with our feet comfortably, about shoulder width apart. And if you can stand here without holding on, beautiful. You can do this for 20 seconds or 30 seconds. Even just standing here with 2 feet is great for your balance. The next option is to put one foot slightly in front of the other. This makes things a little bit more wobbly. But if you can maintain this, then this becomes a great way to practice your balance. If you feel unsteady with this one, don't move on to the next one. But if you feel that this is fairly simple, fairly easy, you can move on. And we're going to put one foot straight in front of the other. Now, usually this is where things get really challenging for people. If this is doable for you and it doesn't feel like too much of a challenge, then you can move on to just standing onto one foot. But the rule for balance, and this is a mistake that I see commonly, is that people try to do things that are too difficult. Standing on one foot is actually very challenging. And so if you don't have great balance or you're not confident, it's not a good exercise to just have you stand on one foot. Because if you are practicing your balance and you're just standing on one foot and falling over, and then standing on one foot and falling over, or standing on one foot and grabbing a chair, if the exercise is too hard, you're not going to actually improve. So you actually want to work at a slightly easier level, something that you're more successful with, and then work on increasing your endurance or changing the surface that you're standing on, or making the balance a little bit a balance challenge, a little bit more dynamic by perhaps trying to do dual tasks. Hold your balance and count backwards from 100. Hold your balance and name all the colors that you can think of. Hold your balance and try to do a little bit of math in your head. You know, you can do things to improve your balance without having to work at a level that's too difficult. The analogy that I like to use is if your goal is to lift 100 pounds, you don't just put down a 100-pound weight and just try to lift it. You start with a 5-pound weight, and then you do a 10-pound weight, and you work your way up very slowly to 100 pounds. With balance, it's the same. If you can't stand on one foot, don't practice standing on one foot. Practice standing on 2 feet with a narrow base of support, or practice standing on 2 feet and closing your eyes, or practice standing on 2 feet and do a cognitive task, or try to carry on a conversation with someone, or move your head and see how that might change your steadiness. So I encourage you. A lot of people think balance is so simple, it's just standing on one foot, but the truth is that that's too difficult for many people. So scaling back and making the task much more manageable is the way to succeed. And now I'm going to move on to a few exercises.
Oh,
oops,
sorry.
Sorry,
No,
Amy.
I thought. Oh.
Just a few exercises that I want to demonstrate. Again, you can try these with me. We won't do a ton of repetitions, but try them with me and just see how you feel. We're going to get all the leg muscles especially engaged here. You do have copies of all of these exercises in your slide decks that are going to get sent out, so you don't need to write these down or try to take videos or anything. I'm just going to run through these fairly quickly. Okay, the first one, and you can just hold on to the back of a chair. You can hold on to the kitchen counter, bathroom counter. We're just rising up onto our toes and lowering down, rising up onto our toes and lowering down, up and down, up and down. The next one is very similar, holding onto a chair. I'm gonna go this way. Raising the leg out to the side and coming back down. Raising the leg out to the side and coming back down. Now, again, don't make this task too difficult. We don't need to go all the way out super, super high. You get the benefit, even if you just go a few inches out to the side and come back down. This actually works both hip muscles. The next one that's on the slides, I highly encourage everyone to work on their legs. Now, you don't have to do squats or lunges or anything really difficult or challenging. All you need to do is stand up and sit down. Use your legs to get out of a chair. If this is too difficult, if you find you need to use your arms, that's fine. Use your arms to stand up, but then try to sit down without using your hands and really get those legs stronger. You can use the hands to stand up, and you can slowly sit down, get those leg muscles working. And the last one here is sort of what we discussed, taking a different approach to balance. So a narrow base of support, either with 2 feet, 1 foot slightly in front of the other, 1 foot directly in front of the other. You don't have to stand on 1 foot to improve your balance. So I would say the goal with that one is maybe 20 to 30 seconds and letting yourself wiggle and wobble, but not fall down. Okay, Amy, now I'm finished.
Sorry, my timing just got a little mixed up there, folks. Thank you so much. That was it was nice to have a little movement during a webinar for a nice change and great information. And again, to everybody out there, just a reminder that we will be, I'm going to share my screen here. We will be emailing out a copy of slides later today that will have examples, visuals, and examples of all of the exercises, the tests and the exercises that Kathleen just demonstrated. So let's move on and get to talking about what to do in terms of making adjustments to the environment around the house or when you're out in the community sometimes. And techniques that you can use to change your communication, to decrease the likelihood that somebody's going to experience a fall. So first, talking about the environment itself, we actually covered some of this at the beginning of the program, but just in summary, so you see it all together, the primary environmental problems that will increase the likelihood that somebody's going to have a fall and an injury at home. Inadequate lighting. Lighting is critically important, and happily, it's one of the easiest problems for us to solve. So not having adequate lighting is a risk for all of us, and especially for people who are living with dementia. Clutter, especially clutter that interferes with the person's most commonly used pathways, right? The routes that they tend to take the most. I think in many homes, there are rooms a person or areas of rooms that a person never even enters into. If that's where clutter needs to go, you know, that might be the safest place for it to be. But keeping those pathways, especially those pathways that a person uses in the middle of the night, right? As Kathleen was talking about, if you're taking medications or for other reasons are up in the middle of the night to use the restroom, please be really sure that the path between the bed and the restroom is clear, that there's some lighting, that there's no clutter, that all of these trip hazards that are important around the house to address, especially in that path to the restroom, especially important. Having a really low seating, was there something you wanted to add there?
Yes, I'm sorry. I love to interject during this area.
I'm so glad, please.
I would say one thing that we don't think about is things that are not always there. So especially in my practice, what I see is around the holidays when people are putting up Christmas decorations. And especially for someone with dementia, when the environment has changed, they're not going to think to look out for the cord for the Christmas lights or the cord for that, you know, adorable moving dancing Santa.
Yes.
And then when it's hot in the summer, often we're using fans, and fans have cords. And so depending on where the fan is set up, make sure that that cord is nowhere near where people are walking, because that's another thing that people aren't, even those of us with absolutely no cognitive decline are going to forget that the fan is there in the middle of the night when we're on our way to the restroom. So just think about things that change seasonally, either holidays or hot summers or, you know, whatever.
Yeah, absolutely. It's a really great point. Clutter isn't just sort of collections of things. Clutter can be temporary, but just as dangerous. It's a really, really great point. Thank you so much. So thinking about the height of places where the person sits or lies down, right? How low is the seating, their recliner that they tend to spend a lot of time in, the couch, the bed, the toilets, all of these things can be elevated. So when they are especially low, because of the issues that Kathleen has described, when they are especially low, the person is likely to have a fall getting up or down from lower surfaces. Stairs and steps, I think that's probably pretty intuitive, but it's really important that handrails be installed, even when there's just one step around the house, whenever possible. This is not always feasible, but any change in elevation for all of those changes related to the visual field that I was describing earlier are exceptionally high risk. So installing handrails, having things well lit, important. Thresholds too, even just a simple change in the surface between a tiled room and a carpeted room. right? Those types of thresholds can be problematic. Slippery floors, especially when combined with inappropriate footwear, either, slippery socks or bare feet, if the floor is especially slippery, can be a problem. When you're outside, cracked and uneven sidewalks. I know in my neighborhood, this is an enormous risk to all of us out there trying to get our exercise to maintain our strength and our balance, but we have to do so on very cracked and uneven sidewalks, a big problem for many of us in a lot of areas of San Diego County. So something to be aware of, looking for paths that have safer places to walk. And pets, I almost hate to bring this up because pets have so much benefit in so many ways, but just something to be aware of. They are an incredible, they cause a lot of falls. Cats, dogs getting underfoot, either on a leash or not on a leash, just around the house, they are a fall risk. I am not suggesting that you shouldn't have pets, just suggesting that you be especially mindful of that. Yes.
So a few ideas on the pets.
Great.
I've had patients succeed with putting a bell on a collar for a cat or a small dog, especially the small pets. You can't always see them underfoot, especially with the visual changes.
Yeah.
And so a bell, it gets annoying, but at least you always know when they're coming. The other thing that people use is baby gates. Things that you would use to keep a child out of a room, you can also use to keep a pet out of the bathroom, out of a certain area. And it's just a way to control them and make sure they're out of the kitchen. Make sure they're not getting underfoot when you're trying to do something like cook or clean.
Yes, great point. The kitchen was always the place where I tripped over my dog all the time, because of course she wanted to be right there ready for a scrap. So thank you. Those are wonderful additions. So as we were talking about the problems, as is my habit, I did already sort of start to talk a little bit about the solutions, but let's just make sure we've covered everything here. So bright lighting and the use of night lights in particular, again, especially in those pathways between bedrooms and bathrooms, but anywhere that the person might be likely to go when it's dark. When we talk about bright lighting in people with dementia, it's important to remember we don't want just bright lighting coming just from above. If at all possible, if you can install night lights, they may need to be motion sensitive night lights, or even just stick on those little adhesive tap lights, whatever works, so that there's some light coming up from above as well. This is especially helpful for people with dementia because what it does is it eliminates so much of the shadow. If you are in a room with lots of bright overhead lighting, that's good because you're able to see the environment so well. But if you're living with cognitive impairment related to dementia and you are prone to delusions or difficulty comprehending visual and other types of sensory information, what that bright lighting can actually do is cause a lot of confusion because I'm now seeing my shadow moving along the ground with me. So just be aware that having lighting coming from multiple directions can be especially helpful there. I talked about just considering the patterns of a person's movement around the house, place special emphasis on safety considerations in those rooms, spaces, pathways that they tend to use the most. Clearing space as best we can so that there's enough movement for the person and any equipment that they might need to use, but also for you as a care partner. If you or someone else is providing physical support, you want to make sure that there's enough space next to the chair for you to provide that support, for example. Removing those obstacles, hazards, and clutters we talked about, elevating those chairs, elevating beds, or installing handrails to help. If you can't elevate a toilet seat or you can't elevate a bed or a couch, there are these sort of temporary rails that you can install to let the person be able to use their arms a little bit more if that's needed. Handrails, grab bars. So again, installing handrails wherever it's feasible, or installing good, sturdy grab bars. I hear physical therapists now referring to them as balance bars instead of grab bars. And I like that terminology a lot, right? Thinking about in the shower or in the kitchen, not just in the bathroom, places where you might want to grab on for better balance. Yes.
I have to comment. But
Please.
I like balance bars as well. It goes back to what I was talking about earlier about just that sense of touch, including our balance. The grab bar is not to grab onto when you're already falling. That's, I think, why we're trying to rename them,
I
remarket them,
like it.
rebrand them. It's to grab onto for extra sensory input as you're stepping into the shower, or to hold on to when you put your head back and try to wash your hair, you
Yes.
know, to prevent the fall in the first place, rather than to grab onto when you're already falling. So
Yes.
balance bar,
Wonderful.
we'll
I
rebrand them.
like it. I like it. You may be the source of that term in my mind. I'm not sure. I love this term. And it also just sort of helps people who are younger, people who don't have dementia, sort of think about ways that they could benefit from having these in different areas of their homes as well. We all need to take care of our own fall risk. So I love that. Thinking about the surfaces of floors so that they're not too slippery, right? Thinking about rugs is one thing, right? Those are trip hazards. We want to take down rugs or remove them altogether if we can, but also just sort of the surface of rugs. There are non-skid mats we can install in slippery areas of the kitchen and the bathroom in particular, easier to install those, but just take care to address really slippery areas around the house, either through adapting the surface of the floor itself, installing, you can buy little pieces at the hardware store, pretty inexpensively, little pieces of sort of tape that have a rough surface, right? That will give the person, provide some more friction. And then of course, taking care not to be walking around in stockinged feet or in slippers that are not sturdy, right? Mule style or slippery bottoms, not helpful. In bathrooms, kitchens, places where water tends to accumulate, drip, spills. Spills can happen in any room, of course. Just get those cleaned up promptly so that there's not standing water, drops of water, or other liquids lying around anywhere. Repairing those damaged surfaces, taking care of those sidewalks or the patio that's got a big crack in it. That can be expensive work, I know, but taking care to repair those damaged surfaces is really helpful. And thank you for those excellent additional ideas on managing pet care, super important. So just a note, I already sort of covered some of this, but just a note to say there's lots of really helpful devices and equipment out there. Your local home health supply store can help you with this, drugstores, basic hardware stores, your local Ace Hardware or other hardware store, you can find most of these supplies. In many cases, they can actually be ordered by, not in all, but in many cases, they can be ordered by a physician and covered by Medicare, other types of insurance, but not always. So handrails, the installation of grab bars, in those high risk areas in particular, raised commodes, ramps to create a safer threshold in and out of a house or a garage. Gate belts, super simple technology, a little piece of a canvas belt, basically, that goes around the person's waist and gives the care partner a way to sort of provide support and guidance while the person is transferring or while you're walking with them without having to grab onto their clothing, right? Or potentially grab onto an arm or a limb, right? And cause some harm. I talked about night lights, rug tape for taping down those throw rugs that if you can't get rid of it altogether, at least render it, get it taped down so it's less of a hazard, and cord covers. I think the point about new cords showing up, this is kind of a part of everybody's life these days, all the devices that need to be plugged in, but also those seasonal things that might appear around the house. Cord covers can be really helpful with that. Just a few notes on communication. I'm going to be brief about this because we have a whole program at Alzheimer's San Diego devoted to this topic, but just a couple of things with regard to communication, which can be helpful if you're supporting a person who's at this elevated risk of balance problems and falls because of dementia. Just at all times, keeping your use of the language and their difficulty potentially comprehending your language or written language, keep that in mind. You don't want to make assumptions about a person's level of understanding about things that we are saying. Talk less. This is like the hardest communication technique for any of us, especially a person like me who's very verbal, but just learning to provide more in the way of visual cues and saying less can be very helpful. Slowing down the speech, speaking in very calm tones, speaking very clearly, articulating, making sure you're in good sort of physical view, making eye contact so they can see your whole face and your mouth whenever possible. This is obviously not always possible, but all of these things will really help improve the person's ability to understand, because then they're getting all that visual information at the same time. Perhaps the most difficult of the communication techniques, but one of the more important, is just learning not to argue, not getting into sort of power struggles, correcting, arguing, just instead just sort of learning to agree with whatever the person is, whatever their version of reality is in this moment. It's generally safer, more productive for both of you to just, okay, I see that that's how this person sees this in this moment, instead of trying to reorient them or correct them, bring them into your own reality, sort of join them momentarily where they are and respond to the feeling that they're expressing, rather than getting all tripped up on the facts of whether or not it's correct. I don't use a cane, right? You might hear something I've never used. Why would I use that, right? In that moment, you're not really going to get anywhere trying to argue the point. So just sort of, we call this validating, providing reassurance. I see what you're saying. I hear you. And then sort of quietly moving on. Much easier said by me than done by you. I know that. But again, I want to encourage you to attend our communication skills class if you want to learn more about how to employ those techniques. And finally, just being mindful of the person's personal space. Remember that if a person is living with dementia and doesn't have good insight or awareness into the changes that are happening with them, and many people with dementia don't, they may have no idea why you are right up in their space trying to help them with things, right? If you're trying to provide balance, steadiness, and help with their balance as they are getting up from a seated position and they don't know that they need that help, just be mindful that that might be confusing to them. So we want to approach people in a respectful kind of a way, being mindful of their need for personal space and mindful of how much they understand about why we're there and what we're doing. So in summary, the tips and techniques that we've talked about: keep as strong, as flexible as possible, both of you, not just the person living with dementia, but you, the care partner. You have to have strength and good balance in order to be a safe provider of care to a person living with dementia too. So be mindful of your own changes to your own gait, your own balance as well. Have that medication review that Kathleen was talking about. Know the side effects of the medications that you take. Anything that might increase your or the person's risk of falling, talk with your doctor or your pharmacist about that. Could it be dosed at a different time of day? Could something be adjusted about that to lower that risk? Eating healthy, staying hydrated. I think hydration is maybe one of the simplest and most common sense techniques for reducing the risk of falls that people just don't think about, how frequently changes to blood pressure, dehydration, all of those things can affect a person's balance. So staying hydrated and yet achieving that balance so you're not rushing off to the bathroom in too much of a hurry and not paying attention and having a fall, right? There's a nice little, there's a point somewhere right in the middle there. Get your hearing and your vision checked regularly. I think it's obvious how our vision affects our balance, but it's actually really notable that hearing loss, hearing changes, which are very, very common in the general population, most of us are going to have some significant hearing loss by age 65. Get your hearing checked regularly because it also affects your balance, but also your ability to sort of regulate your movement if you're experiencing a balance problem or a fall. Just sort of slow it all down, give yourself plenty of time, right? Not getting yourself into situations where you have to rush around, you're trying to multitask, you're carrying too many things up and down the stairs. You can see I'm using that example often because it is something I need to work on in my own life and in my own home. Doing that visual cueing, giving people visual feedback as well as saying things verbally. When you are providing assistance to someone, sort of providing social chit chat, maybe setting a movement or an exercise to music, to a rhythm, right? Whatever that might be, something that is easy for them to sort of follow along to, that gets their movement into a nice rhythm, can be really motivating in terms of providing that support. Be as positive, as affirming, giving lots of praise. You're doing a great job, a reassurance all along the way in whatever way feels natural and comfortable to you and that person, right? If clapping your hands and saying great job, doesn't feel natural and would make the person wonder, what you're doing, right? Just adapt this to whatever sort of communication style is natural for the two of you. But yes, you've got it. You're doing a great job. Yes, that's it. Right? Providing lots of that verbal validation that they're doing well can be really helpful. And again, just to emphasize this point again, we want to really help people feel as autonomous. Independence is not really a worthy goal in this situation. We can't really get people back to the level of being independent, but we can help people be autonomous and feel in control and in charge of their space and their daily tasks and their daily lives. So doing what you can to just come alongside, do things with the person rather than to them or for them can be really helpful. So I'm going to turn things back to Kathleen here to talk a little bit about recovering from a fall if it does happen.
Okay, so again, I think the biggest mistake that I see when people have had a fall is they are in too much of a rush to get up, or your loved one has had a fall and it's so scary, you want to get them up as quickly as possible. Really, the best way to address a fall is to first stop, take some very calming breaths, and take inventory of what's going on. Is there pain? Is it just pain from sort of the shock of the fall, or is it pain from an actual maybe injury? Quick body assessment. Can I move my head? Can I move my wrists? Can I move my legs? Can I move my feet? If everything's moving and there's not extreme pain, we're probably okay and we're able to get up. But if we try to just immediately sit up or immediately get up without taking inventory, wastes a lot of energy, because it's actually hard to just sit straight up from a position where you're 0 miles per hour on the ground. And so we want to very carefully and slowly roll onto the side that hurts the least, or the side that is the strongest. Usually everyone has a better knee and a worse knee, or a better shoulder and a worse shoulder. So move to your strong side to play to your strengths. And then we want to kind of use gravity to the best to help us as much as possible, rather than to try to pull ourselves up against gravity. And so that means maybe getting up onto hands and knees, maybe just getting onto one side, and getting ourselves into a sitting position, a half sitting position, or even maybe a kneeling position. And there's a video that we're going to watch together that will demonstrate this. Use a chair or something to help you up. Even if it takes longer to stand up, it is better to crawl over to the couch or crawl over to a sturdy coffee table, whatever you have nearby, sturdy being the operative word there. It is better to spend some energy getting to something to help you up than to try to stand up on your own from the floor. Your legs and your arms are going to get so tired just trying to stand up without help. And then you're not going to be able to crawl to the chair over there. Keep the hands on whatever device you found for support, so that you don't fall again. And try to get into a seated position. Take lots of rest before you actually get up and get to the phone, or get help if help is needed. But yes, the rest and the approaching the recovery slowly is the most important aspect. I've had several patients, unfortunately, have a fall, sort of, a little bit panic, try to get up, exhaust themselves, and then end up just lying on the floor for a while until they can gain back some of their energy to ultimately get themselves up if they're alone. So we're going to watch this video on the next slide.
It's a slow start, but it'll get started here in a moment.
It's important to check the person who fell for injuries and call 911 if needed. Only attempt to help the person if you feel that both of you are able to safely work together. Otherwise, call for assistance. To help someone up from the floor, they will need to get into a crawling position. If the person is on their back, help them to bend their knees up, reach across their body in the direction they want to go, and roll over onto their side. Help by gently pushing at the hips and shoulder areas. Now help them to bring the top leg out in front of the bottom leg. Place your hand under the shoulder touching the floor and lift the person so they can pull out the arm and rest on their hand. Now, move your hands to the hips and help lift them up and over, allowing the patient to get onto their hands and knees. Guide the person in need to crawl close to a sturdy, secure piece of furniture and place their hands on it. Help them to pull their knee forward and place their foot directly under the knee. This should be done with the leg they feel is the strongest. Come around to the other side of the person and help lift them to stand by hooking one arm under their arm and placing your other hand on their back. Remind the person to lean forward while pushing up with the bent leg and both arms. Have the person stand for a moment to make sure they are steady and not dizzy. Slowly turn and sit.
I do like this video, but I, of course, have commentary. Keep in mind everything that Amy said about the visual field. And you notice that the caregiver was actually out of the field of vision of that person if that person has Alzheimer's. And so make sure you're communicating with the person you're caring for and make sure they can see you because they're already going to be a bit panicked from the fall. The other thing that I will say that I think is underrated, crawling is wonderful, but I know most adults don't crawl hardly ever. And it's hard on the knees, it's hard on the hips, it's hard on the hands. And again, it's not a familiar activity. So it's not going to be something that's intuitive to someone who has cognitive challenges. So I'm going to demonstrate, I always end up on the floor with these presentations, but I'm going to demonstrate another really valuable, especially if you have a chair or something close by. You don't have to get all the way on the hands and knees. You still are going to roll onto your side as in the video, because it really does make getting up much easier. So you're going to roll onto the side, the strong side, get into this sort of partial sitting position, and you can scoot from here. You don't have to get all the way on your knees. It's possible to move around, especially if it's only a few feet, you know, a bit like a mermaid would move around, sort of dragging those legs behind you. Just because, especially if anyone has artificial knees or just some arthritis in their knees, they're not going to want to actually crawl and they may not actually know how to crawl. And then you're trying to explain to someone, it's actually a complicated movement. Right hand forward, left knee forward, left hand forward, right knee forward. So take some of that out and make it a more natural movement, scoot.
I had a question for you. Actually, you halfway addressed it actually, but after watching that video, I wanted to ask you about in the narrator refers to the when they're starting to stand up, that you have them get up on the foot of the leg that they perceive as the strongest. So we may not know that as a care partner. It probably would be a complicated question to ask a person. Could you generally just sort of assume it's a right-handed person, their right leg might be stronger, or is that not a safe assumption?
I'd say don't mention it at all. Let them kind of naturally move. Okay. You know, I think even someone with dementia, we have a lot of movement is automatic.
Yeah.
And if I asked you, Amy, which is your stronger leg, you might not know.
Yeah.
And then if you add that after I've just had a fall, I'm all shaken up, I can't even make heads or tails of what's going on, you're especially not going to know then. But if I just said, Amy, bring your foot forward, you'd naturally bring forward your stronger foot.
Got it. Okay.
And then if that doesn't work, try the other one. So I think your point earlier about not trying to give too many instructions and not trying to make tasks as simple as possible and try to demonstrate as much as you can. I think in a situation like this that's unfamiliar and scary, that's even more important. Less instruction is better. Let the person naturally do, what they want to do. I do think that the place where you can help the most is getting people to roll onto their side first, because I do find that people spend a lot of energy, on their backs and then just trying to sit up, which is hard for all of us.
Yes.
Especially if we're a little bit weak and a little bit scared and we just had a fall, if we're stiff, you're going to waste so much energy just trying to push yourself up. So rolling onto your side puts you in a position where it's a much easier to maneuver from your side. So that's the place where I would definitely intervene and then kind of watch what the person does. They may naturally push themselves up into sort of that half-seated position, and then it's much easier to navigate from there.
Great. Well, that's it for my questions. Gabby, how about other questions?
Yeah, we have 2 questions. The first one is a person is wondering, they have stairs with one handrail. So how might they install balance bars for additional support?
So I think it depends on how the stairs are set up. If it's a really wide stairwell, one handrail might be your best option, honestly, and just training whoever it is, whether it's the care partner or if it's yourself, to hold on. Keep in mind that the handrails are for that extra sensation, that extra input for the brain. It's not necessarily to pull you up the stairs. And so if it's a hallway, if it's, a more narrow type staircase where you have the option to put handrails on both sides, that's something that I would call a handyman or a contractor about to actually install. And there are some services that I'm sure, Amy, you guys can point people to for actually reduced price or even free handyman work for small tasks like grab bars and balance bars and handrails and just sort of general easy repairs. But I'd say if there isn't a space to install a second handrail, the best thing to do is to train yourself or your loved one to use the handrail every single time.
Right. If I can just add to that too, yes, there are services here in San Diego County for free or low cost installation of not only railings and balance bars, but other types of minor home modifications. We can help you connect to those resources. But one of the pieces of advice that was given to me once by a contractor, there are certain types of contractors called certified aging in place specialists, CAPS specialists, who do this to make these types of modifications to make homes safer, not just for people with dementia, but for all of us. And one of their pieces of advice was that second handrail, like if a hallway or a stairway is really wide, you think, well, why? I could never hold both of these at the same time. How is that going to help me? But remember that there might be a care partner next to the person going up and down the stairs together or walking down the hallway together. And that might be an extra point of balance and support for the care partner too. So, which I had not thought of. So throw that out there too.
Thanks. And then we have one more question. Do you guys have any suggestions on how to encourage doing these exercises? Whether that's with a caregiver or classes via Zoom?
I'll start, and then Kathleen, I'll hand this off to you. But my best piece of advice is to do it with the person, if at all possible, modifying it however you need to, but not just sort of setting the person down in front of a screen or dropping them off at a class and hoping they're going to participate, but getting involved and making this a thing that you are doing together. You might even frame it as like, I need to work on my balance. Do you want to join me while I do this? Any other suggestions, Kathleen?
I think especially if you have somebody who hasn't been moving at all, Don't make the goal to do a 30-minute class or YouTube exercise video. I think make the goal to do 30 seconds at a time. You know, make it really, really small and make it part of your routine. So before we get up for this meal, we're going to stand and sit 5 times, and then we're going to eat our meal. And before we go to this appointment, we're going to stand and sit 10 times, and then we're going to go to this appointment, and we're going to do it together. You know, or, you know, let's, as we're preparing a meal, or as we are brushing our teeth, or as we are doing some activity of daily living, let's also rise to our toes and come back down 10 times together. And, you know, get these little small bouts, because every little bit helps. And when you have difficulty with initiation, it's not realistic to assume you can do 20 minutes of exercise all at once. So I think make things really small, and don't even call it exercise.
Yes.
Just call it, we have to move a little bit more. We all need that. So we are going to just do a few extra movements as part of our day. You're still going to get pushback. In a perfect world, yes, you know, you'll just do it together, and then realistically, maybe it'll work 10% of the time, but 10% of the time is more than you were getting before. So I think set expectations that are realistic, which is, you know, I hate to make this comparison, but I think it is valid. I have a 2.5-year-old, and really, he listens to me about 10% of the time. And it's the same thing. I still repeat the same things over and over again, but it gets through. It does get through, and you'll get some buy-in at some point. But don't create a situation where expectations are too high, and therefore you're not going to succeed. The other thing that I recommend is, I think that most of you can probably agree that people who are experiencing dementia tend to spend a lot of time in front of the television. And so there are programs. The county television channel has like a Feeling Fit Club. I think it's once or twice a day. They have a yoga class once or twice a day. That's just part of the regular scheduled program. And so sneak in there and change the channel, or don't sneak in there and just tell your loved one, we're going to change the channel. We're going to watch this together. I need to exercise. I'm going to exercise in this room with the television on. If they're sitting there and there's nothing else to do, they may actually decide to participate in a small fraction of it.
I'm so glad this question came up. All of those pieces of advice are so valuable. And it reminds me to say, so this is a skills clinic that we're doing right now. This is a series, so we do them on a regular basis. And the very next topic, not coincidentally, is called movement and motion. And it will be taught by a kinesiologist and a caregiver wellness researcher on this exact topic, like how to kind of get little bits of movement and motion incorporated into your day-to-day to improve their quality of life as well as yours as a care partner. So great.
Thanks. Those are all the questions at the moment.
Great. Well, in our final few minutes here, I'm going to talk about some resources for additional help, including some of those online, televised and online resources that we were just talking about. So just a quick note that conditioning is required for you too, right? Being a caregiver is physically demanding. Even if you're not the live-in, hands-on, day-to-day caregiver, this is an exhausting journey. We all know that. So taking care of yourself, making sure that there's something in your cup, right? So you've got something to pour into another's. This is all really important. So we want you to be thinking about your own strength, your own balance, and your own mobility, not only because it makes you a better caregiver, but it makes you a healthier person. So here is some information about a few of those resources that Kathleen was mentioning. The city of San Diego, if you live within the city or can easily get to it, has a variety of adaptive classes that are free or very low cost. You can find them. You're going to be emailed a copy of all of this, by the way. Don't rush to write down all these links and names here. You're going to have all this in writing. So therapeutic recreation services, the Feeling Fit Club, the healthierlivingsd.org website will take you to a whole host of, including that county TV station, where they air those regular programs. SDSU has a really wonderful adaptive fit fitness clinic for people who are living with disabilities. Silver Age Yoga does live Zoom classes as well as in-person yoga classes these days. And Silver Sneakers, many of you may be familiar with this, but this is a Medicare benefit, and it's also covered through other types of health insurance as well, both online and gym-based health and fitness programs for older people, if you fall within that category. So just some different types of support we want you to be thinking about, and just to know that we're here to direct you to. I saw a few minutes ago, Gabby put a link in the chat where you can fill out a form to request information from a member of our clinical services team. So if you need some additional help with any of this, some in-home care, information about, locating a physical or occupational therapist, getting respite. So you're getting a little bit of a break so you can go do some of this important self-care from time to time. Please reach out, let our staff know, and we will help you find those local resources. There's information about the Feeling Fit Club, and San Diego has a marvelous group of professionals that come together in something that's called the Fall Prevention Task Force, with a lot of great information on their website. And then just a couple of other resources I want to point you toward. UCLA has a terrific library of caregiving videos for dementia caregivers that might be useful in some of your daily care tasks. And the Family Caregiver Alliance has a wonderful set of tips and videos regarding transferring safely. So just some additional resources we hope might be helpful. Here we are, Alzheimer's San Diego. All of our programs, supports, services, everything that we do is provided at no cost because of support from wonderful members of our community. We really appreciate that. So please reach out if you need to find one of these education programs that we're talking about, you need help locating a resource, you want to find a support group that would be a good fit for you, you'd like to engage some of our volunteer services. We have companion volunteers that can come in and provide in-home or virtual visits to keep a person sort of occupied. Maybe they can do some of these exercises together with the person that you're caring for and might be more successful at it because they're sort of a new face and a new voice making that ask. So lots of options out there. We offer a variety of resources and supports. And again, it's all at no cost to you. So please don't hesitate to reach out. You can find lots of great information on our website. Call us anytime, email us at that main email address, or even live chat us from the homepage of our website. And again, that form that is out in the webinar chat, you can fill that out and a member of our clinical services team will happily reach out to you to get you more information. So just a couple education programs coming up we want you to know about next week. We're doing what we call our drop-in education hour. These are really fun. It's just an unstructured hour with a couple of members of our education team to just answer whatever questions are on your mind. So if you maybe go watch the communication skills webinar that I mentioned before and you have some questions about how to try some of those techniques, that would be a great place to get those questions answered. So that will be next Wednesday around the lunch hour, at least here on the West Coast. That will be our lunch hour. We'll be doing a program the first week of April on the topic of driving and memory loss, a very important and difficult subject for a lot of folks. So those are just a couple of the programs that are coming up. We have a robust schedule of live education programs, as well as a pretty in-depth webinar library of recorded programs too, all available on our website. So that is it. My thanks to you, Kathleen, for a terrific, as always, presentation. I'm sorry we didn't get to do this in person together, but on the other hand, so many of you wouldn't have been able to attend. So I'm so glad that we could do this. Gabby and Cora, we really appreciate your help and support in the webinar here today. And all of you, you're going to be directed to a short survey. We would love your feedback on this program and suggestions you have for other topics you'd like to learn about as well. Please share. It's anonymous, so we want you to share openly and honestly with us. We really value it and use that feedback. So thank you all so much. Everyone has a great day. We'll see you next time.